Hi, everyone. My name is Ted Barbeau, and I'm a growth director at Patient Ping. Thanks to Joe and the rest of the WISHIN team for giving us an opportunity to participate in today's event. We're here to speak with you about CMS's e-notification condition of participation that goes into effect on May 1st. My colleagues, Kirsten Lundquist and Ben Marquardt, will walk you through the rule and its requirements, as well as the solution Patient Ping and WISHIN have developed for hospitals in Wisconsin to achieve compliance. Kirsten is a senior product marketing manager at Patient Ping. In her role, she oversees all activities related to bringing Patient Ping products to market. She also played a central role in shaping our strategy to effectively support hospitals as they prepare to meet this condition of participation. Ben is a strategic account director at Patient Ping. In his role, he works directly with Patient Ping customers to develop care coordination strategies using real-time data to impact patient care and cost. Additionally, he works with compliance and IT teams to ensure that their ADT sharing infrastructure will meet the requirements of this condition of participation. I will turn it over to Kirsten now to give you an overview of the rule. Kirsten?
Thanks so much for the introduction, Ted. First, we're going to start with a quick overview of the two major interoperability rules that were passed during the year 2020. So on March 9th, 2020, two significant health IT rules were finalized, and on May 1st, 2020, both were published in the Federal Register. Those being the ONC Cures Act, or the info blocking rule, as some know it in the industry, and the CMS Interoperability and Patient Access Rule. It's no coincidence that the two rules were finalized and published in the Federal Register on the same days, as they are meant to be complementary in many ways. Both rules focus on information sharing and ensuring data can be readily exchanged to improve patient care and outcomes. Today, we'll focus on the CMS rule and specifically the e-notifications condition of participation provision of that rule. I want to spend a minute on the intent of the rule, as it's important for the context and understanding of the requirements. Patients in the US healthcare system receive care in lots of siloed settings. While some information sharing across the care continuum is of course already occurring, CMS has recognized that existing information sharing among providers is insufficient. CMS has introduced a new condition of participation, the most significant and consequential regulatory lever that CMS has, as COPs determine a hospital's certification status and its ability to receive CMS payments, to help eliminate barriers to information sharing, to increase care coordination, to improve care quality, and improve patient outcomes. Information sharing across the continuum is essential to care coordination, which in turn drives improved patient outcomes and CMS cost savings in its many value-based care programs. CMS has had success in driving cost savings via its value-based care models, with their flagship value-based care model, the Medicare Shared Savings ACO program, generating $1.2 billion in net savings to Medicare in 2019. As CMS drives more providers towards taking on more risk, they recognize that more information sharing is essential to providers improving the quality of care and succeeding financially by driving down the total cost of care in value-based care models. Now, to summarize the e-notifications condition of participation in one sentence, hospitals must send admission, discharge, transfer, or ADT notifications in the inpatient and ED settings to post-acute providers, primary care practitioners, and primary care practice groups and entities. CMS gave hospitals 1 year from the publication of the final rule in the Federal Register to come into compliance with the new regulation. So compliance is required by May 1st, 2021. We will dive into deeper detail on the regulation in the coming slides. The rule requires that real-time notifications be sent by hospitals directly or via an intermediary, and the regulation applies to the following types of hospitals: short-term acute care hospitals, rehab hospitals, long-term care hospitals, psychiatric hospitals, children's hospitals, cancer hospitals, and critical access hospitals. All of these hospitals who receive payments from Medicare and have medication participation agreements are subject to this regulation. Now, these notifications need to be sent to providers in the community, including patients' established primary care practitioners, their primary care practice groups or entities, including ACOs, POs, FQHCs, and other primary care practice groups and entities, post-acute care providers, including SNFs, home health, hospice, and other post-acute providers, as well as to any other providers identified by the patient as being primarily responsible for his or her care at the point of care. The notifications must at minimum contain the patient's name, the treating practitioner name, and sending institution name. Now, only hospitals that use EMRs or other electronic administrative systems that have the capacity for notifications conformant with the HL7 2.5.1 standard will be subject to the COP. Just to note, pretty much every major EMR that has this capability already, so most hospitals will be included as hospitals that are going to be subject to this condition of participation from CMS. We know from the final rule that the e-notification requirements will be part of the medical record services condition of participation category for hospitals and psych hospitals, and the clinical records condition of participation for critical access hospitals. Based on the procedures outlined in the State Operations Manual for the Medical Record Services Conditions of Participation category, the survey will include two main components, those being a review of the organizational structure and policies and an interview with the head of medical records, and second, a review of a sample of active and closed medical records, totaling 10% of the average daily census of that hospital and no less than 30 records. For the policies, hospitals need documentation that can explain how hospitals meet the notification requirements and what procedures they have in place in order to do so. For the records review, you'll need to be able to show through something like audit reporting that notifications have been sent to the specified recipients in the rule for those randomly selected patients under review. The survey team will formally document any deficiencies on Form 2567. And as I'm sure you're all aware, hospitals will need to address deficiencies within the timeline that is specified in the CMS termination procedures. That means hospitals have 10 calendar days to submit a corrective action plan, so the ability for rapid remediation will be essential should you not meet compliance standards. So what does this mean for what hospitals need to do in practice? In practice, hospitals must have the policies, processes, and systems in place to send notifications to all required recipients specified in the rule by the May 1st, 2021 deadline. To bring that to life a bit, I'll walk through three scenarios here. The first is sending a notification to a patient's primary care practitioner or other provider that is identified by the patient as being primarily responsible for their care during their hospital encounter. This requires a process where patients identify their PCPs and any other provider, which is at the registration. This is something you probably already have in place as part of your registration process. It also requires access to a directory of providers' digital contact information, as well as a mechanism to push direct notifications to correctly match providers in real time. The second scenario is when patients associated with primary care entities, like an ACO or post-acute care organization, like a home health entity that a patient is on active services with, when they have events at your hospital. Many patients do not know and can't proactively tell registration workers who their current home health provider is or the ACO they are affiliated with. Simply relying on patient-reported attribution here can leave hospitals exposed on delivering notifications to all required recipient providers in the community under this COP regulation. The last scenario is when a CMS survey team visits your health system to evaluate your COP compliance. You will need to have supporting audit documentation to support the patient medical record review portion of the audit, plus documented policies and procedures that will be reviewed by the CMS survey team. In order to meet compliance requirements, hospitals will need two foundational capabilities to ensure notifications are sent to all required recipients in the community. In order to send notifications to patients' community providers, you're going to need to be able to attribute them correctly to their community providers. This can be done via patient-reported attribution or provider-reported attribution. Hospitals will need to be able to send messages in real time to PCPs and other providers identified by patients at the point of care. Notifications based on patient-reported attribution. As I've said before, this will require a registration process where patient-identified providers are documented, and hospitals will need access to a provider digital contact info directory and an ability to push notifications in real time to those matched providers and their digital contact information. To ensure community post-acute and primary care entity providers receive their required notifications, hospitals can take in requests for notifications from community providers in the form of rosters of patients which they have an established care relationship or provider-reported attribution. This can involve numerous complexities centered around executing data sharing agreements, processing diverse roster types or patient panels or census lists, and managing frequent and real-time changes as provider-patient relationships change often, especially in the post-acute landscape. Now, that's the requirements and the foundational capabilities hospitals will need to come into compliance with this regulation. But to bring it all together, I want to review some of the critical considerations that you need to keep in mind as you determine how your hospital will meet this new e-notifications condition of participation. In particular, as you evaluate solutions, you should consider and ask how the solution will meet these 8 points. So let me briefly walk through them. First, consider how you will identify and send notifications to post-acutes, and how you will send notifications to cross-regional providers who are eligible to receive notifications and need them for treatment, care coordination, or quality improvement activities. You should consider how you will manage and ensure you have the appropriate data sharing rights, security, and trust in place between you and the recipients of notifications based on patient events at your hospitals. You should also assess how you'll ensure that notifications are actually sent in real time and are not unreasonably delayed or batched. We talked about this quite a bit, but consider how you will manage and fulfill continuous provider-patient relationship changes and to manage the many endpoints of where notifications need to go. And as we just talked about, what you will use to demonstrate compliance once you get surveyed? What help will you get to ensure you have audit documentation in place so you have peace of mind that you are actually sending notifications in compliance with the regulation and can use that documentation to demonstrate that to survey teams. And something we haven't actually talked about, but is very important to consider, is how you ensure that community-based providers, those notification recipients that need and want notifications from your hospital, have an optimal and excellent experience in this process. You rely on those providers for referrals, and you send your patients to them for ongoing care, and you want your brand to lead in the market and be a good partner for those referral sources in the community. These cross-continuum partnerships and provider relationships are critical for patients' experience in their care. So making sure this e-notifications condition of participation actually helps the overall information sharing effort, and making sure that other providers have a positive experience in all of this will be critical and can set your hospital apart from others. Finally, of course, you'll need to consider how you will meet compliance by the May 1st, 2021 deadline. It's fast approaching, and you should be considering your compliance strategy and how you will meet this compliance separately sooner rather than later, as the deadline is only in a few short months. And with those considerations in mind, I'll now hand it over to my colleague, Ben, who can give additional information about patient ping, our compliance solution, and how we can help assist hospitals as they look to come into compliance with this new regulation.
Thank you, Kirsten. Hi, everybody. Our partnership with WISHIN began in the summer of 2018, and it's really a perfect partnership. It allows us to pair WISHIN's deep Wisconsin roots, incredible network, and rich data set to Patient Ping's national network and ability to share real-time events and care coordination information on patients as they transition throughout the care continuum. And this iceberg graphic you see is really, it's a wonderful representation of that partnership. And think of Patient Ping as the high-level surfacing of information visible in real time. So we're that knock at the door. We let you know your patient's having an event, where that event's occurring, and some high-level context on that event. And then WISHIN has that deep clinical data set that provides a wide swath of information on the patient. So paired together, care teams are triggered to take action in real time to reduce cost and improve quality during those vulnerable situations and care transitions, while having necessary patient information to make informed decisions that lead to those better outcomes. And I mentioned that we have a shared network with WISHIN. And when you look at that network, you'll see many logos already working with Patient Ping and WISHIN in Wisconsin today. And you also see a map of the Midwest. And the thing to call out there is patients travel. And knowing that your patients are going to travel, having insight into those patient events as they travel, gives your care teams more power to act quicker and identify the patients that need your help the most. And so what you see on the map is the red dots that you see are hospitals, the blue dots are post-acute facilities, and you'll see 390 hospitals, 1,950 post-acute facilities throughout part of the Midwest. Nearly 100 of those hospitals and over 100 of those post-acute facilities are right here in Wisconsin. And so that network gives you the ability to see those events and take action as those events are taking place. Now, to transition from our partnership with WISHIN and tie a couple things together, I want to tie together the rule that Kirsten just talked about, but also that network that we just talked about. The rule requires sending data to providers in real time across geographies and technologies. Our national network of live facilities today is closing in on 1,200 hospitals and over 6,000 post-acute facilities. We already have the nation's largest collection of providers requesting e-notifications as it currently stands. Now, you're probably starting to connect the dots that this is a rule that requires real-time data and sending e-notifications, and it matches our business model really well. But as healthcare IT sits today, there really hasn't been a fully baked solution to account for all of the nuances that Kirsten just described in the rule, while also matching the rule's intent. So we've created Route, your single source solution for compliance, and one that fills the gaps that I just mentioned. With Route, you'll be fully covered anytime a patient attributes themselves to a provider through our direct messaging program. We also have a way of capturing the provider requested attribution through our requester landing page that you'll see momentarily. And finally, we have you covered with front and back end audit support to streamline things for your teams during a survey. Essentially, with Route, you're fully outsourcing the work to be compliant with e-notification COP. Let's dive in a little bit further to see what each of those look like. With patient-identified notifications or patient-attributed notifications, many of you might be familiar with this project or this process already, and some of your EMRs might be doing this, at least some of this for you already. And what this is a patient shows up to your hospital, your care teams capture information about that patient, including their provider. We capture that provider NPI on the ADT feed and bounce it off of the best-in-class HISP that we're partnered with. And that HISP bounces back the direct message address associated with the NPI that allows us to send that direct message. All of that takes place happening in an instant to satisfy the real-time nature that this rule requires. The next piece is the one that hospitals tell us they have a little more anxiety over. The rule states that anyone with a treatment, care coordination, or quality improvement relationship with the patient is entitled to notifications. But as Kirsten mentioned, someone like an ACO care coordinator working with a patient on care coordination or quality improvement may not have a direct message address, and the patient might not be able to identify them. So hospitals have wondered, well, how do I account for this? We've created a requester landing page. It's a digital asset that we can put into any of your public-facing websites. And what that allows is when a provider has a need to receive e-notifications on their patient events at your facility, they simply go to your public-facing website, go to the requester landing page, fill out this information, and that comes straight to us at Patient Ping. We'll validate any of those incoming requests, we'll manage all data sharing agreements, and we will work with them to install their roster onto our platform and match those patient events through your ADT feeds. And from there, the provider can pick how they'd like to receive that notification. So as Kirsten mentioned, many health systems are looking for ways to improve provider relationships in the community and love this approach as it gives them additional ways to support their community provider partners. To prepare you in the event of an audit, we've created a couple reports that you'll have access to. Our national aggregator report will show you who's requesting your e-notifications and where they're going, while our on-demand report shows you every notification, the status, where it was sent, and by what method. During an audit, your team will be able to move quickly and efficiently to find the necessary information. And I mentioned earlier, we have front and back end audit support. This is a little bit more about that back end audit support. To address the front end audit support, you'll also need to have your policies and procedures guidebook. We will write this guidebook for you, and we also take care of training your team on it. So during a survey, when they want to see this guidebook and that the policies and procedures are in place, you'll have that covered and your teams will be trained on how to use it and explain it to the surveyors. And we've had conversations with CMS since the rule was dropped. We feel strongly in the fact that our solution not only matches the intent of the rule, but also covers you for all those little nuances of the rule as well. And that's why we're willing to attach a compliance guarantee. If you're ever found to be out of compliance during an audit, we'll provide on-site support to help you develop that corrective action plan that Kirsten mentioned within 10 days. And finally, we thank you for your time and listening to us today, and we'll leave you with the resources you see here. We'd love to hear from any hospitals that might still be searching for a compliance need or are just unsure if you're protected today. Enjoy the rest of your conference, everybody.